You're listening to the We Are Libertarians podcast network. Find all of our shows at wearelibertarians.com.
Episode 135, The Paradox.
Welcome to The Paradox with your attending, Dr. Eric Larson. He is a practicing anesthesiologist and clinical assistant professor at Michigan State University College of Human Medicine. Listen in as he takes you behind the scenes of what practicing medicine in today's ever-changing world is like with another doctor. The Paradox is a fun and accidentally informative show for physicians, patients, or anyone who has ever found themselves in a waiting room.
Welcome to The Paradox. I'm your host, Dr. Eric Larson. Thank you for joining me as we explore the U.S. medical system in a fun and informative format through expert analysis. In today's expert, I'm delighted to have Dr. Douglas Farrago. Dr. Farrago is a recently retired DPC physician, and he's one of the pioneers of the DPC movement. He's certainly been one of the best advocates for the movement as he runs the DPC News website. He's also been a prolific writer on authentic medicine, where he's been blogging for almost 20 years, I believe. And today we're going to talk about Apple and basically tech in general, or tech companies, I suppose, to be more precise, and how they've entered the primary care space and have flopped. Why have they flopped? And what's the real solution to fixing the problems? You can guess what his ideas are, but I think you're going to have a lot of fun with this discussion. We talk about how you just can't replace people with technology. And speaking of people, I'd like to welcome Dr. Irritate, and I hope I pronounced your name correctly. I'm so sorry if I didn't, who's a new patron and join the Paradox family. You can go to patreon.com/theparadox. That's Paradocs. And for a small monthly contribution, you can support the production and promotion of the show, and you can interact a little more easily with me, give me show ideas, and possibly even get on the show. So join the Paradox family today at patreon.com/theparadox. But now a word from our sponsor. And today's sponsor is Physician Financial Services, a business widely recognized in the physician community for disability insurance. Lawrence B. Keller, CFP, has been in the insurance and financial services industry since 1990. Unlike medicine, which has a standardized path that physicians must take to gain the education, training, and experience requirements necessary to obtain board certification, the insurance and financial services industry does not. While he might not be a doctor's first phone call regarding their insurance needs, he is often their last. Find Larry at drpodcastnetwork.com/Larry Keller or at the link in the description of the show. Finally, if you haven't subscribed to the show, what are you waiting for? It's free. Hit the subscribe button in the podcast player of your choice. And if you haven't, what are you waiting for? It's free. So be sure to hit that button and go back into the archives if you haven't had a chance to listen to all the shows. I'm sure there's one or two that will pique your interest on a topic other than COVID or DPC. We strive here to find solutions and people who are disruptive who actually solve problems and not just point out the problems in medicine. So I'd like to think we have a nice balance of both. But without further ado, how Apple failed at healthcare, doctors didn't, with Dr. Doug Farrago. Enjoy. Well, hey, I'm here with my new friend, Dr. Doug Farrago. He's a family physician who is now recently retired as of October, but he was a direct primary care physician at Forest Direct Primary Care, which he started in 2014 in Forest, Virginia. He'd worked a number of other jobs in, I guess we'll call it corporate medicine for lack of a better explanation, up in the Northeast. He's also written 6 books: The Official Guide to Starting Your Own DPC Practice, The Direct Primary Care Doctor's Daily Motivational Journal, and Slowing the Churn in Direct Primary Care. He invented a couple things like the knee saver, which you see the catchers wear if you watch baseball. It's in the Hall of Fame. He also invented the cryo helmet for head injuries and migraines. He was the editor and creator of the Placebo Journal, which is sort of a humor magazine journal, I guess, from 2001 to 11. He's been blogging since blogs began in early 2000s at Authentic Medicine. He's currently the editor of the DPC News website, which can be found at dpcnews.com. And he also helped found the DPC Alliance. So clearly this is a guy who's an advocate for direct primary care. Dr. Farrago, thanks for joining the show.
I am, and yeah, you're welcome. Love to be here. Anything we can do to push that ball or that boulder up the hill from DPC, I'm always there.
Well, I have loved direct primary care physicians for a number of reasons. One is they're super easy to get on the show because they always have time. You talk to most docs you talk to, like, well, if I take myself for example, I've got hours where I'm working and I can't make schedule time in. I'm not in primary care, so I'm beholden to an operating room, and so that's probably always going to be the case, even if I were to do some other way. But direct primary care docs, they say, oh, okay, I'll just pencil in an hour this time or whatever, and I'm not super busy. I'll just not see patients for a little while, and it's pretty easy for them. And also they are all very happy. I mean, I'm just finding happy ones, but yeah, they are. There is definitely the push to be in business, and then they're running a practice, but there's a lot of the things that are outside their control. I think that's one of the big selling points of direct primary care, that at least these physicians feel like they are more in control of their practice and how they work than they are in most other settings.
I 100% agree, and they're passionate. And they want to spread the word, so that's why they'll get on podcasts too, right?
Yeah.
I mean, if you didn't care so much about your topic, why would you want to talk about it on a podcast, right? If you just wanted to see your patients and go home, which a lot of doctors who are in the industrialized matrix model don't want to talk about it, right? And then they're burning out and frying, where DPC doctors always want to talk about it because they want to convert the masses.
Right. Well, we're going to talk about a couple of articles that you've written recently that are going to be on the paradox.com website. You can go to paradox.com for episode 135. So first, it's the one that you wrote on Apple, which I thought was very interesting. Why don't you kind of talk to us about Apple, which everyone knows the brand Apple, and it's a technology company. And they thought, well, we have all these devices. We have all these ways of capturing data, right? Everyone out in Silicon Valley says we have lots and lots of data. And so there's a lot of useful things you can do with data, and there are lots of things that are not very helpful. So why don't you talk about Apple's foray into medicine?
First, I'm not an expert in data. I'm not an expert in Apple. And this article was in the Wall Street Journal, but it's just a similar theme that I saw all the time. That Silicon Valley and big tech's just going to solve healthcare. Ain't going to happen, right? It's just not. It's an adjunct, right? Big tech or technology is an adjunct to what we do. And they want to replace us. Remember, the goal is always to replace physicians. I don't know, consciously, subconsciously, financially, whatever. Even though we're the smallest percentage of what's using of healthcare dollars is physicians. You would think, oh, it's a big slice. It is not, right? They still want to replace us because it's corporate. The world thinks they're smarter than us too. So if you read the Wall Street Journal article or my article on DPC News, Apple says that we're going to do it with our Apple employees. We'll just kind of have a subscription model using our data, and we'll get another doctor, I think I forget his name, but he was going to run it, and that thing blew apart. I mean, it never worked. The engagement was low by employees because they weren't paying and their skin wasn't in the game. The doctors, and if it was doctors, I think there was turnover, their skin's not in the game. And it just shows again why direct primary care is the way to go. You can't replace doctors. I'm sorry. They're going to try, but they can't do it. Now, I think their tech is interesting, but sometimes I point out in my article too, not all data means crap. I mean, actually a lot of data is crap, right? It's just noise. I love my son to death, but he wants to capture his blood pressure every day, and like, dude, you're 20-something years old, right? I don't need to know, and no one needs to know that data, right? I mean, you imagine, I would bet you the false positive of anything wrong on people, especially young and healthy, is tremendously high. And so what data is important? Well, it looks like we've been doing medicine for how many years, hundreds of years in this country, and so we kind of know how to carve away some of that stuff. And so that's it's an adjunct. You can use data. You got to know what to use. But there's also that face-to-face knowing your doctor, that personal relationship, which DPC has. And I point out in my article too, it's like, that's why when you see these cool doctors like Joseph Bell, who I think he's in Scotland, who 100, 200 years ago, I forget how many years, but how his absolute skill of observation, when people would walk in the room, he would teach other students, looking at their fingernails, he can tell what they did, he can tell their limp, he can tell how they held their shoulders. He had every observational skill. He was so phenomenal that one of his students, Arthur Conan Doyle, made Sherlock Holmes after him, right? Yeah. So that's irreplaceable. Sorry, it's just irreplaceable. So that's why I don't believe I think Zoom and telemedicine is good as an adjunct, but sometimes I need to be in the room with you And, from whether it's a smell or a feel or an observation, that you're not going to get through this 2D thing you and I are talking through. So good for them, Apple, they tried. And if they fail, Amazon failed, keep going, buddies. You want to keep trying. Instead of throwing money at, if they literally could throw little bit of money and start DPC practices around the country so quickly. Forward is that DPC clinic in LA, right? You've heard about Forward?
No, I'm not aware of it.
Yeah, so they're a corporate DPC. Now they have 11 clinics, and they had $50 million investment in 11 clinics. $50 million. It cost me $20,000 to start my clinic. Was profitable in a year. When you got your own skin in the game, and you care about your patients, and you care about making this thing successful, you don't need $50 million bucks, or $5 million per clinic. So I just think it's funny. I always like to point that out. Not against them if they want to keep trying, but I think the little guys and the grassroots movement is the way that's going to hopefully break this healthcare system and in a way save it.
Yeah. So looking back at the Apple, essentially what they were looking at is they have, as you know, people have Apple Watches or devices. It records your blood pressure, like you said, blood pressure, heart rate, all kinds of things. And so my impression was they were trying to they basically had their employees enroll in this program. They collect all this data, and then they have someone interpret this data and decide to act on it. And they charge not that much. It doesn't sound like it was, but it was to the point where it was useful information, right? Like it's just gathering, but because it turns out that most people don't need to get seen if they're not sick, right? Right.
Well, I think I think I think they did something called their philosophy was that they want to break that. They call it 363 because people only see them twice a year, and they want to fill in that 363 days. Yeah, something like that in that article, right? Okay, so, but let's just stand back. You and I both physicians. We stand back and say, okay, wait a minute, hold on. What's the population they're dealing with? What age group? Okay, what's the odds of any of them having hypertension or AFib? And so what are we looking at here, right? So what else is that watch showing? Oxygen. What's the odds of them having desatting? None of this data means anything to me right now, right? In fact, but when I get in front of you as a patient, as a 24-year-old, and because of the amount of high tech, social media, and addiction to tech, I can find the high anxiety and depression that's going on and see that. Yeah, right. That's not picked up by. Tech is causing that, and they can't pick it up. And if you think I'm exaggerating, this was a 50% increase in ER visits for people with anxiety and depression, especially over COVID. But high tech, that was going on before because of technology, social media, and so forth, right? So they're all causing that problem, and yet they think they're going to fix it. Yeah. And they can't even pick up the problem they're causing.
Well, it seems like a fundamental disconnect in recognizing. So this is like medicine, right? Like you have to diagnose the problem before you can, just because you have symptoms, it doesn't tell you what the problem is, right? Someone has a limp. Well, it might be because they have a leg that's shorter than the other because of a bad hip replacement, right? There are all kinds of different possibilities. You have to figure out the actual problem. And so when you see someone say, well, healthcare is expensive, well, we just need to, do this X, Y, or Z. Well, if you're not actually approaching the right diagnosis, your treatment's not going to work. And I think you've seen that with these technology companies. They think that one, it's the physician expense that's is called driving the care, or the fact that people are not staying healthy, right? Like if we just did more preventive care, we'd save tons of money. Although probably if you look on average, preventive care is more expensive than not doing it. It's obviously of more value to people to not get sick or have
I believe we all believe in preventative care, and I think a lot of primary care doctors spent much more time than they ever had before talking about diet and bringing processed foods down, bringing carbohydrates, especially simple carbohydrates, down. And actually was interesting if you look at COVID and who really got the most sick was probably the metabolically most disturbed, insulin resistant people. And so could we have used that time to, maybe this is an aside, could have used that time to say, hey, listen guys, this country needs to work on our diet better because insulin resistance and metabolic syndrome, really, those patients did really poorly with COVID, but we all know that's taboo to ever, dear God, talk about COVID. But yeah, so we talk about it. And I think preventative care is great stuff if you have the person in front of you and you know the person and during their physical, because I do believe in the physical exam. By the way, they're trying to get rid of the physical exam because they don't feel who they are, which is the people like, who is that? The U.S. Preventive Task Force and Cochrane stuff. They always debate whether a physical exam was worth it. And I'll never give up on that, or never did, because that's how you learn about that person and pick up things that wouldn't have been picked up. And if you look at the model, it's models based on cost. So when you look on some of the evidence, well, why wouldn't you have physical exams to everybody? Because they can't get them all in. Well, we could.
Yeah.
So if you could, and you had the time, and it wasn't an expense because it's part of their membership, and a very cheap $75 a month membership, you really do pick up a lot of stuff, right? I mean, when you think about the guy who took over for me, I had a conversation. It was really enlightening. I said, why are we? The evidence is not doesn't show that you should check for a TSH or thyroid. It's not. The evidence doesn't show that's appropriate for a screening. I'm like, why not? That was because of cost. The cost is so high. It's the only reason, because if you get a TSH come back at 10, you're hypothyroid. I caught so many people way before they were symptomatic. And so, Cochrane and everybody else says, well, it's not cost effective. Well, what if the cost is $10? Because that's what the cost is in our office. That changes the whole game. That changes the whole paradigm. So and our labs were like that. A CBC is $5. And so if you did a CBC and someone's, white count was 2 out of nowhere, that was worth it. Those kind of things, I think, are at least debatable. And so, so that's what's cool about direct primary care. You start thinking about, okay, well, what labs really be worth it now for patients? And versus that whole model that we were taught in the industrialized model is based on a mass cost thing. And now this is much more personalized in primary care.
Right.
So you can do some of that stuff.
And I think the two important points there that you mentioned is, one, it's personalized. And so you're not treating a population. You're not looking over 1 million people and deciding how many people you need to do colonoscopies on or something like that. You're looking at the person in front of you, and you take into account, what they're worried about, their family history, all those sorts of things that you can individualize. And then also the fact that your costs are so different, all those calculations, like you mentioned, you've totally changed them, right? Because they say, well, it's not worth it's $1,000 for this test. Well, if you say, well, now it costs $10, or my physical exam's free, it takes me 2 minutes, I'm going to do it anyway. That's right. I mean, that's the whole thing. The reason they say, well, if we only have 20 minutes or 10 minutes really for a patient interview, what do we spend our time at? And then you say, well, maybe you don't do the physical exam because you've got a certain amount of time but if suddenly that's not a barrier, well, then obviously you do this thing that's free. Why wouldn't you do it?
Right. And it changes. It changes. It really was almost, it freaked out your mind a little bit. You're like, nah, everything's open to me now. Right. That's why it's like the Matrix, right? You're out of the Matrix, which is, with the system, and you start thinking, well, now I can really start talking about, well, let's look into cholesterol. What is the better cholesterol test? Well, we don't want to do the NMR because it's too costly. Is it too costly? No, it's not. It was down like $40 versus the old crappy lipid panel, which was, so now you're really digging deeper in what kind of, and so it's great for you as a physician to even learn more and find out more really what we can really help patients and are they at risk versus a blanket statin for everybody, I just think that that's a really cool thing. So I'm not against even the technology, right? So patients that want to have a look at heart rate variability intrigues me, right? I mean, I think there's something there. Sure, if you want to, and I can explore that with you as a physician. I can explore continuous glucose monitoring, even if you're not a diabetic. There's some thoughts there. I'd love to be, and patients. But at me as a big tech saying I can fix this with my tech, you ain't doing that.
Yeah. Right. Yeah. Well, it's certainly interesting thinking about all those things that you couldn't do before. So the other thing I want to talk to you about is, and this goes, my wife's a pediatrician, so she has all kinds of times she gets patients who call in with problems, right? Kid has a fever, sore throat, whatever, earache, pulling on his ear, all the usual sorts of things for pediatrics. Which is, in many ways, I've always thought, and most people do, it's like veterinary medicine for kids, like small children, because they can't tell you what's wrong with them. You have to sort of use observational skills or physical exam skills. The only way you can actually figure it out, or the history from the parents. And it's very interesting because there are people who promote telehealth and this, I don't want to say impersonal, but certainly not an established relationship with a certain physician or provider, we'll call it, which I hate that term, but we'll just say that. And without having that personal relationship, you don't know that person, obviously. And so someone has a problem, you feel totally different about it depending on who it is who's telling you the problem, right? So my wife will say many times, like, well, I had this person call me, fever. I wasn't worried because she's always calling about fever. This mom's always just kind of worried about it. I just reassured her and she's okay. Or she has someone who's like, yeah, when she thinks her kid's sick, there's something really wrong and I have to come in and see it. And like, I got to see you or I got to see this kid. And that sort of differentiation is something you can't get for just like, I don't know. There are these services like, $10 a month or something like that. And I can't imagine you're getting anything of significant value for that, except maybe peace of mind if you're the kind of person who'll never use it. But I don't know. I have a hard time believing that's going to provide any sort of valuable care that you could get elsewhere.
I'm 100% on board. I agree with you. I mean, first of all, for $10 a month and they go up to a little bit more, who are you paying? Who are those providers, right? I mean, and that's another issue I have is, the issue of, I think education and training matter. And I think doctors have to be physicians, right? And so not that there's not a role for a team, but if you're paying people now to mass, not doctors, who are now seeing tons and tons of patients on a 2D screen, obligated to give them some medication because they want to give them, that's what these people are paid for.
Yeah.
Bastardize this job, right? So that's not helping medicine. That doesn't create access. It may create access, but it's crappier access. Now, I don't have the answer to make access better for everybody. And I've been asked this before. I just interviewed by a reporter, but like, well, there's not enough doctors to do DPC and there's too many patients. Like, well, that would create more in the long run. It wouldn't happen right away, but in the long run, more medical students most people go into medicine initially in their head. I know you became an anesthesiologist, but a lot of people want to be an all-around doctor, but then they realize how much we make and we're seeing 30 patients a day and we're making the lowest in the end scan. They don't do it. But we make a little bit more in DPC, maybe the same, but we're really getting to know our own patients. It's a quiet, relaxed environment. When I was in practice, 99% of the time, no patient ever saw another patient in the office, didn't even ever see one. It was so relaxed. And it was a nice feeling to get to really do what I was trained or I dreamed of it being when I was younger. So yeah, I think the 2D screen telemedicine is an adjunct. Again, just like the watch could be, and if you pick the right thing for that watch, could be. So I don't believe these services are going to take over. I don't think they're good for medicine. Sorry. And that's going to get some people mad. I mean, I think there's some role for some of them, but not all the time. But it is what it is. It's still patient's choice, but I in my mind, I can't get past the personal connection I have with my patients when I was in practice and to see them in person, for that observational, intuitive kind of skill that we were trained and you get from 140,000 visits over my career.
Sure.
I don't know why I picked up certain things that I would walk in a room and pick up after a while, but you can see why you could learn that by just repetition. Yeah.
Well, I mean, I see certain people at church. I'm like, boy, I hope I don't have to intubate you. Right. I mean, I immediately recognize.
Yep. There you can see the blue bloating, right. I mean, I'm sure that's what you look for. And I'm sure you're looking at their, how easy to intubate they would. I'm sure looking at their jaw too, right?
Oh yeah. Jaw, the airway. And, I shake your hand. I'm checking to see if you've got nice veins in your hand. I can't even help it, but that's just what happens.
Yep. I'm the same thing with moles. Whenever I'm on beach or anything like that, I'm like, I cannot, I've told more people I've never met, dude, you got to check that out. I'm a doctor, so, so I'm a doctor for life. I get that, but, yeah. So again, maybe they'll get better at these things, but, I've caught some amazing things out of just nowhere. Patients were not coming in for that. And I'm like, what is that? And, whether it's a melanoma on a nail or whatever, right? I mean, we gotta, yeah. So, so I think there is traditional medicine, I'll go back to the first thing I said, which just can't be replaced.
Yeah. Well, I feel like DPC is sort of the red pill for primary care. It's, the matrix, like you said, right? I mean, I think it's a way of certainly getting back to your roots, I guess. And I've oftentimes thought too, with the amount of paperwork that people do with the computers now, and without a doubt, the amount of clicks or non sort of clinical work you have to do as a primary care physician, we know it's increased. They keep track of these things, and it's like about half your time, or maybe it's even more than half now, that your time is spent not clinically. If you cut that by 40%, you've increased your physician coverage by 40%, right?
Yeah.
I mean,
Yeah.
and so the shortage is
what are they doing
maybe
with this data anyway? What are they doing with all these quality metrics? How is that help medicine?
I don't know, but I know when I have patients come in for anesthesia, I know whether they wear a seatbelt or not. I can tell you I don't care. I mean,
how is it? I mean, we've been doing this for how long now, right? And it was always going to, these quality metrics are going to help healthcare. Hasn't done it all. In fact, it's been proven to not work at all, right? It's only for insurance companies to sell that data, right? They parcel that out and sell it and make more money off us.
right.
It does nothing. What's the one metric they never measure? Time with patient.
Right.
They'll never measure that because they don't want to tell anybody that. Where we spend all the time with patient because we don't have any of that. All we do what's called a SOAP note, and in our simple EMR, and we spend all this time with patient. I don't do any of this garbage quality metrics. I don't. If someone's coming for and they're having chest pain, I don't need to be asking about their seatbelt at that moment, right? So this is stupid stuff that's been added to us by others, and this is what I get in trouble for because I rail against our organizations who agreed to every one of these metrics.
Yep.
They agreed to every one of these coding things. They've agreed to every one of this EMR stuff. They've obligated us all to it and sold us down the drain for no reason. And now you have burnout. And then guess what? They're the answer to your burnout. They have all these courses now for your burnout. You caused the freaking burnout, right? And in fact, we're going to help your burnout. We're going to call it resilience. So just take this other extra work course online about resilience or whatever. They have no clue what they're doing. No clue. They've caused it all. And then they want to help fix it. And you got to pay for that. So direct primary care breaks that bondage, right? It breaks the bonds from that. And, there's other stressors in DPC. You got to own your own practice. You got to worry about who's paying the gas bill and stuff like that. But you don't have to worry about the metrics, the indicators, the billing, the coding, the denials. I'm going to get this to a level 4 if I just buff this chart. Are you kidding me? We've got to that point. Everybody, I've done this in my lectures. Every single doctor I know, including myself, have lied about the review systems. Everyone. We put that whole thing in there that we ask all those questions, please. You've never asked all those questions, right? And if you did it so fast that it was like an auctioneer. So for a fact, right? So that's another thing. Review systems not proven as any way that's ever helped anybody, right? By sitting there and wailing through a review of systems, it actually gets you off the trail of what's important for that day. So yeah, this is all, we created this crap for ourselves. Our organizations gave the okay to the insurance companies and the government, and then we're stuck like that. And then by taking the red pill in DPC, we're out. So
you run the DPC News website. You have, I'd say you have as much a finger on the pulse of DPC as anyone in the country.
Yep.
I people oftentimes ask me when I try and tell them what DPC is, they say, well, it's concierge. I say, well, not really. There are some DPC docs who say it's concierge because people understand what that is. Yes. But it's, membership based. And I understand from a marketing standpoint why some DPC docs do it, because in their affluent area, that's what people want. And so, they can call themselves whatever they want as long as you're DPC, I guess, who cares? But where do you think the trajectory is of DPC right now in this country? I mean, my impression is, at least watching all the practices opening up, is that it's not exponential, but it's growing quickly. Would you agree with that assessment?
It's linear and not exponential, unfortunately.
Okay, sure.
It needs to be exponential. And I'm doing whatever I can, to help that along. When I started, I didn't want to do, I was retired And like, I'm like, oh my God, all these articles come out, all these practice announcements, all these tips come out, and it's on Facebook, which gets washed down the river like a pebble, and down the Niagara Falls. It's gone, right? And so no one's collecting this information. Like, crap, let me ask. I don't want to step on anybody's toes. Does anybody else want to do it? No one wants to do it. I'm like, I've been doing a blog, my other blog for 20 years. I can set up a website and collect on DPC News practice announcements, marketing tips, practice tips, DPC docs in the news, politics about DPC. It's pretty easy to do. And we put a piece up every single day because I think I want this movement to grow more than anything. It would break my heart if somehow it got stopped, because it's the purest part of family medicine that I've ever seen. It's not rocket science. It is a membership model, which is kind of a newer thing, but now people are understanding subscription models because everything, Netflix,
everything is, yeah.
Microsoft Word, you'd buy it once, you have it forever. Now you got to pay a monthly fee, right? Something like that. So they're getting that. But I do this when I talk in a lecture, and like, if you had someone in the audience transported from a 1930s doctor in the audience, and the doc up there was lecturing, was talking about all these things called direct primary care, how you don't have to deal with insurance. Patients have time. They know their doctor. They can go see him at their house. That doctor in the audience in the 1930s, like, it's been 90 years. You've not changed a bit, because that's what we do, right? I mean, that's what they did. The only thing difference is we have some of this technology, the texting, the email, and it's that membership model. But yeah, you bring up the word concierge. Concierge is an article I do we have on the site that explains the difference, and it's not so simple. If you're billing insurance, you're not direct primary care.
Correct.
Anyway, right? Right. And then I actually use the term in my marketing, because I was early. I said it's concierge care at an affordable price.
Oh, okay.
That's the way, because people understand that concierge service, right? I don't love that. I don't love concierge because it does sound, for the rich. So that's why I added the affordable price thing. But then that begs a difference. If you have we can't define, like, where is there a cutoff point? We were about $75 a month. So if someone said $1,000 a month, well, that's obviously concierge medicine. So, but then where does it meet? So where you cross over the line, no one really knows that. Is 100 too much? Is 150? That sounds like a little too much. You know what I'm saying? So there is the bottom line, it has to be a membership model. You can't bill insurance, and it should be affordable for most people. That's the way we kind of define it.
What do you see as the biggest barrier to DPC growing at this point? Is it the fact that most people are still getting their healthcare through insurance networks, and so for them it's an added expense, outside of insurance? I mean, that's what it is for me. When I first signed up, I actually was on a health share ministry sharing plan, and I've now got insurance again. But anyway, that's kind of a different story. But anyway, so I just got my doctor, and we have that anyway. It's a great service. But do you think that's the main barrier right now for most people?
Well, the two barriers are that physicians who don't want to jump into it, because you have to go from the salary to spending money to making no money.
Sure. The risk.
Money. So that risk is a barrier on the physician side, and so that's one side. The patient side is they don't understand that they're hooked on a model that is absolutely, they're addicted to insurance, and so they think it's a great thing, and they're realizing it's costly, and then they're realizing they're covering less and less, but they think they have to have that. Now they have to have something for catastrophic. We all need something, and I'm not even against if that was national, some kind of catastrophic coverage, but then the rest, let people shop around for their health care. We're the best shoppers, in the world. Amazon proven that in their, just a regular Amazon market, because in the long run, I think you do save money most of the time with direct primary care. If you go 3 or 4 times a year and get any labs done, you've saved money by doing us. Insurance is paying less and less. I mean, they may not pay for anything they pay for a fasting glucose and a fasting lipid panel. They're done. Okay. I find this laughable too, because I'm a big advocate of like good RX, right? So I can try to get you a cheaper medication. Okay, so then I'm finding more and more that insurance is covering no medicine. They were realizing people are shopping and getting cheaper medicines at GoodRx. They're like, we'll just cover nothing.
And charge the same.
They're not covering anything. So you're paying cash for your medicines. You're getting less and less from these insurance companies. And so And that's because they shouldn't be, and they're not a healthcare provider. They call themselves a healthcare provider. So do your commercials for hospitals. As your healthcare provider, blank health, hospital, you're not. It's the doctors and nurses that are healthcare providers, right? So the insurance model is yes, that is the number one barrier, because people just don't understand how freaking bad it is and how costly and what little you're getting for your money. You still have to have something, but where did it go? Where did the major medical go 40 years ago, where it was just catastrophic? Why couldn't that? Where's the commercials where it says where say take 15 minutes to save 15% of your health insurance? Where are those commercials? Right? I mean, it's a scam out there.
Yeah.
And unfortunately that confuses patients, and we try to really truly educate. And so and I teach everybody else, I mean, no patient should join your practice without a meet and greet. So they truly understand what they're getting into. And they ask that question, why do I need you plus insurance? And I would say, listen, you go to a doctor office, it'll be $150 a visit. There's a copay. Any procedures, they'll charge you a lot of money for. If I take a mole off you, it's free. If I drain your cyst, it's free. If I put an injection into you, it's free. I'll see you when I need immediately. If you need to come back for a second problem or you want to just stay longer, we can do either way, but it doesn't cost you anymore. So you kind of work on your pitch, which I think is totally legitimate and you're a salesman. We're all salesmen, and we sell ourselves because we really believe we have a great product.
Yeah. So when you're seeing, do you see lots of new residents and medical students? I mean, at least now when 10 years ago, not even 10 years, let's say 5 years ago, when I talk about it, a medical student, I had three heads, right? When I used to talk about direct primary care, they'd never heard of it. I feel like now they've heard of it or they're aware of it. And so something has shifted and changed. At least kids are aware of it, whether they want to actually do it or not. That's an entirely different question. But are you seeing that too now? At least more physicians are looking at it?
Much more. When I started, it's in my book actually, and I did a talk at the residency. Yeah, none of them, they thought it was illegal.
Getting paid to work.
There's no idea. And now I was getting tons of residents and medical students shadowing me by the end, and it still continues today. So listen, this is the thing that drives me crazy. And I've had my ups and downs with the American Academy of Family Practice, but I beg them to ask one question, to all their members, just one question. If your practice, if I can guarantee you, which I can't, but if I guarantee your practice was filled tomorrow, so you won't have to worry about going into debt, filled tomorrow with DPC model, where you're only seeing 6 to 8 patients a day, you're making as much as you have now, no coding, no billing, no metrics, would you take that job on versus what you have now? And I would say 99% would probably say yes, they would do that. So why don't you ask that question? Because if you ask that question and 99% yes, why wouldn't you then make a model or figure out how do you get from A to B? Because that's where everybody wants to go, right? They all want to go DPC, is what I'm saying. And I just think it's going to take some time, but we're not getting as much help as we should be getting.
Do you think the academies are the ones stopping it in some ways? They're definitely, like, I've seen conferences hosted by the family practice. They definitely have the models. Is it just because they don't understand it? I mean, people who are hosting conferences are, academics, maybe, for instance. So they're not in that sort of model anyway.
Well, there is some. Okay, so they are they're reactive to what's in their pool of members, and most of their members, 90% plus, are not doing DPC. So they're going to deal with mostly that, and so I think I do have some feelings they're making money off the industrialized model as well, whether it's teaching you how to fix your burnout or teaching you how to code right or teaching you how to do all that stuff. So I'm not sure that there is some conflict of interest there. I don't think we're high priority right now. This has to be grassroots. And listen, we went to the AFP conference and kind of like broke in and had a party to get people to go. I mean, we did it just to, and I think it kind of pissed them off a little bit, but because it has to be done that way. It has to be only done guerrilla style to show people there is another way. How do you tell people about the matrix if you're in the matrix, right? So it's going to take time, and I'll be long gone before that maybe it's totally mainstream, but I hopefully I can be a part of that, moving it that way.
So now that you've been retired almost a year now.
October.
Yeah. So You're getting there. We're mid to late June at this point.
8 months. Yeah.
And now actually the pandemic's over for the most part.
Yeah.
What do you see yourself doing? You're obviously advocating with DPC News. What other things are you doing besides, having fun, golfing and playing softball, as we were talking about earlier before you were recording?
Yeah. I've written through those 3 books. I've written 3 other books. My latest book is a fictional book called Noki. It's about autistic boxers. It's a really great story. I'm proud of that book. I see myself writing more like that. I enjoy doing that. I enjoy the DPCing. My friends are mostly DPC doctors, so that I can't see myself losing that. And then I'm just going to go with the flow. And I've invented 2 different products. So if something comes up, I don't have any regimen or plan where I probably need to do that more, where I have quiet space and kind of just think. But I have my office here, but when things come to me, I have guys like me. I'm not go like this, right? And so it'll hit a surge of creativity or something will hit, and then I'm lost and I'm gone in that world for a while. Then I'll come back. And right now, I know I'm a little bit of a lull, so something's probably coming soon. But I have no specific plans. I mean, I'll visit my kids who live different parts of the country, and so I'm happy as a clam. Love medicine. Part of me is sad when I start losing some of my knowledge base about it, and I miss some of my patients. But it was time, and we'll see where this takes me.
Finally, with DPC Alliance, where's that organization? Well, I mean, now that you actually can do stuff, right? Because now you can actually host events. What are you guys up to for the next year? Is there stuff going on that conferences and things like that?
So I came up with actually the idea. I'm so proud that we actually all came together. No one makes money in an organization other than Joe Grundy, who's a hired, basically runs the company because we need somebody. But no, all the physicians are volunteer. It's nonprofit. Everybody in DPC should join the DPC Alliance because there's a ton of knowledge-based stuff there. DPC Alliance runs mastermind weekends, at least probably 6 to 10 a year, where you can go and spend time with DPC docs. They also help out with the DPC Summit, which is in collusion with the AAFP. So that's why people get mad at me if I rip on the AAFP, but it's another story in itself. But I do believe in the DPC Summit, and I do believe there are some good people, really are good people at AAFP who believe in DPC. And they're involved with this. So the DPC Summit comes up, I think, this next month. In the future, that'll be live. This one's again virtual, and I don't do virtual conferences. I'll go to the live one and have fun with that. I expect that conference to get bigger and bigger. There's 2 pieces that are missing, and we haven't figured this out. We need a better patient educational model to get patients, because that creates demand for more DPC doctors. Right. We need that. I don't want to do that. DPC News is enough for me. I hope I don't have to get forced into that in some manner. So that is one piece that needs to be fixed. And there are 2 organizations that are involved in lobbying. So I'm not sure I don't think DPC Alliance won't do that, which is good. But I do think they need to be the voice. So I don't want, if Newsweek wants to hear about direct primary care, I don't want them hopefully ever going to the AFP. They should go to the DPC Alliance, and that needs to be known so that they're the mouthpiece. And I'm not involved in any way other than I'm grandfathered in as a permanent member because of that, some of the things I've done. But I'm not even on the board right now. But the people on the board are freaking awesome. The people running it, Julie Gunther, Vance Lassie, Kissy Blackwell. I mean, these are brilliant DPC doctors giving a ton of their time to just move the movement forward. I think that's awesome.
Well, Dr. Farrago, thank you so much for your time. I wish you the best of success in your retirement and doing other things. And I'm sure we'll run into each other, actually in person for once, which would be kind of nice.
It'd be cool if you ever go to any of the masterminds, if you ever go to a DPC conference, or maybe there's some other, the stuff you're doing with this podcast. And great job with that. I think this is awesome. What are they doing for podcast conferences? Do you go to those kind of things? Is that something that intrigues you? Because I'm not going to ever do one. But I'm just curious.
They have them for like national ones. I don't believe there's one for medicine. I'm actually part of the Doctor Podcast Network now, so there are a lot of us, and so I suppose, I mean, it got formed during the pandemic, so I don't know. I think at some point we probably need to get together. Yeah. I feel like most of the physician podcasts are selling stuff. I don't sell anything except I guess I run an ad, but I mean outside of that, I'm not selling myself. I'm not selling my services. I think I like to think that we're looking at medicine and various things in the healthcare sphere, and things are disruptive, and trying to get people informed and learn about stuff. And maybe someone wants to do something about it. I'm amazed, like as you are, about the energy some people have and their creativity and ability to solve problems. Yeah. And that's what I just find. I love just talking to those people, because I in that way I'm not at all creative to solve these problems. I see the roadblock and I don't see the way around, and they do.
Everybody has their niche, and trust me, if anybody has superpowers in one area, they're lacking in somewhere else. I'm just telling you. That's the thing. That's why I tell you this. That my wife has to compensate for a lot of crap that I cannot do. That's why she's involved in DPC News, because there's gaps that I am missing. But I hope we do get to meet each other someday in person.
Well, thanks again. I appreciate it. Thanks again to Dr. Farrago for a really fun discussion on Apple and tech and DPC. But before we end, don't forget to reach out to Larry Keller of Physician Financial Services for your disability insurance needs. He's been around for a while in many physician communities, helping them with their coverage they need. Find Larry at drpodcastnetwork.com/Larry Keller.
Thanks for listening to The Paradox. If you like what the doc is doing, please subscribe and leave a review on iTunes or Stitcher. And share the show with your friends. Become a supporting listener to get access to special bonuses at patreon.com/theparadox. Show notes can be found at theparadox.com.